Hello, everyone. Greetings. I would like to wish everyone a very happy World Sight Day 2021. I am Fakhruddin, and today I have been given this opportunity to share my thoughts and ideas about decoding multifocal contact lenses. Before I begin my discussion, I would just like to acknowledge the support of IACL because most of the materials for today's discussion I have picked up from the ICLC module 2020. And I would also like to mention that I have no financial interests in any of the products which I would be mentioning today. I would also like to thank the Shankara Academy of Vision and the Shankara Eye Foundation India for inviting me to share my experience. So before we begin, let's understand what is actually presbyopia. So the word presbyopia was derived from a Greek word which typically means old eyes. Interesting to note is that this condition will eventually affect each and every one of us because it's an aging process. But the diagnosis of it is known by a very few during the eye examination. So people are not really aware what presbyopia is and how and what it can lead to. Most typical complaint is that patients who are above the age of 40, 42, they would say that I have to now hold the reading material away, and I can now see it clearly if I hold it away from the viewing distance. Or some of them would also say that I require additional illumination to read. But the technicality of the word presbyopia still remains a mystery and unknown to a lot. So let's understand what changes happen due to the age onto the eye. First and foremost, we'll look at the functional changes, the vision function changes, which includes the loss of accommodation. And this is the sole reason why we tend to not see close by objects clearly. There is also reported senile meiosis or reduction in the pupil size, which happens as we age. And there is a reduction in the low contrast VA under low illumination conditions. So these are the visual functional changes which happens as we age. Another thing to note is about accommodation and convergence. So we do understand that accommodation and convergence work hand in hand, and accommodation and convergence demand on early presbyopes warrant some amount of consideration while we are fitting them with their corrective lenses. We also understand that both accommodation and convergence when it comes to spectacles versus contact lenses is different. Typically, when the Rx or the power is more than 4 to 5 diopters, and we know that there is an increased demand on myopes when they are switched in contact lenses, whereas it is converse in hyperopes where the demand of accommodation and convergence reduces when they are switched to contact lenses. So this is something to note because it will be really helpful in fitting these patients with contact lenses. The next thing to note about age-related changes is the structural change, of course. So there has been reports, and by clinical experience, we know that aging has some structural changes on the eye. So we look at the eyelids. So what changes happens in the eyelids? There is the reduction of the elasticity. Patients might have sagging of eyelids. Some might develop ptosis because of the orbicularis oculi, or the levator action is not as great as in young people, and some eyes may also develop ectropia. When we look at the cornea, it is also found that the fragility of the cornea reduces. There is a reduction in the sensitivity, and of course, there is endothelial cell loss due to aging, and we see some changes in the endothelium as well. Structurally, when we look at the conjunctiva, you also see a presence of penguingula or pterygium in old eyes more often compared to the young eyes. And we also note that the tear quantity and quality, production and stability is poorer or reduces as we age. All of these structural changes are really important for us to note when we are thinking about fitting these patients with contact lenses. Let's look at what are the current generations what we are talking about and which generation lies in that presbyopic age. So typically we talk about these four generations: Y and the Gen Z. So when it comes to multifocal or presbyopic corrections, the baby boomers and the generation X are the age group which we are of more concern. But what is more important to notice, all of these different generations have different visual demands. They work at a different pattern. They prefer different electronic gadgets and devices. And this important information is really important for us to choose a proper mode of correction for presbyopes. What do these presbyopes desire? What do they want or what do they look up to? First and foremost is they want to be normal. They do not want to wear any additional glasses for them so that it doesn't remind them of their age. So, if you have to wear an additional glass or spectacles in front of the eye, it actually keeps on reminding, oh, I've gotten old. So they don't want to have that feeling. They want to look normal. They want to have a youthful appearance. They want to be confident and independent of any additional glasses or corrective lenses. And most of them want to be free and flexible, using their cell phone devices to read their SMSs, their WhatsApp, and driving using their GPS systems in the car and all of that. So they want to be more of an independent personnel rather than having any dependency on any types of additional corrective lenses to look at up close distance. And all of these things are really important to keep in the back of the mind as a practitioner, that we need to cater to all of these needs which are mentioned. So what are the current options available for presbyopes? What can we do for them to make them see clearly up close? Very commonest or what I would say is widely used measure is the reading glasses or a pair of readers which they can just put on when they want to see up close. Again, the advantage is they come very handy. You can have multiple pairs in different areas or rooms, and they can just put up when they are reading their phones or book. The disadvantage is it's difficult if they have a distance prescription, whereby they will have to wear their distance glasses, and it doesn't really work when they have a distance prescription onto place. The next option would be either giving them bifocal or multifocal or progressive lenses, whereby they have to wear spectacles full time. So from the top portion of the lens, they will be able to see for far, and from the bottom portion of the lens, they would be able to see up close or for near. And advancements of progressive lenses these days are so very good that most of these early presbyopes and presbyopes tend to get adapted to multifocal spectacle lenses very easily. But again, these are spectacles. So do we have any options for them where if they don't want to wear spectacles? And of course, we have these multifocal contact lenses which are available, and there are some other ways on how we can help them from not wearing glasses but wearing some type of contact lenses with which they can see clearly. And last but not the least, there are certain refractive procedures such as LASIK or laser refractive surgeries which can also be performed for these presbyopes so that they can be having independence from their glasses. So these are the four common options available for presbyopic corrections. So let's look at how can we go about helping them. First and important reason is to identify their needs, to know what do they require to see, what do they tend to see, and what is their routine life activities all about. Occupation plays a very, very important role. You want to understand what are they doing throughout the day, what's their occupation, and depending on their occupation, do they have any specific hobbies which they need to address? And all put together is their daily visual requirement. Do they want to see more of a distance? Do they more want to see of a near task related activity? Is it more of a desktop or a computer use? So all of these information is really essential based on the occupation, the hobbies, and the daily visual requirements put up all together. We also need to weigh the importance of vision versus convenience. So are they more of a vision crisp required personnel, or they are more of a convenience related personnel? Again, this will help you to choose an appropriate lens design in terms of fitting them with contact lenses. So you need to ask them what is their majority in terms of weight. Do they prefer vision to be much sharper, or it's more of a convenience use which they want to wear? It will also help you to choose the modality of the lens, design of the contact lens, and the type of the lens what you're going to suggest or fit these patients with. We also want to understand, are they going to be a full-time or a part-time wearer? Again, this will give you a clue on what type of material would you want to select, because as you remember, there are some age related changes and they revolve around tear production and tear quality being a bit lower compared to the young eyes. So we want to make sure what full-time or part-time wear are they going to do. What are their vision priorities? Is it, as I said, distance a priority, or the occupational demand requires an intermediate or a near as a priority? Do we have dry eyes, or are the patients suffering from any dry eye dysfunction which we need to deal? Because again, if we are talking about contact lenses here, we are going to put a contact lens on the eye which is going to disrupt the tear film. So we want to make sure we do not cause them discomfort. And we know that discomfort is the primary or the major cause of contact lens dropout. So we want to be cautious if we want to treat or if we are going to encounter dry eye symptoms while fitting these patients. What activities, if there are any specific activities that could affect the lens wear and the design, or it will also help you to choose the material. For example, they want to have contact lenses only for a specific task, socialization, probably once a week or twice a week. So you can probably advise them multifocal, which is a daily disposable lens, rather than having a monthly disposable modality. So those are something which we need to ask our patients and understand what are the activities they would be using these lenses for. How much of an astigmatism do we need to deal with? So look at the amount of astigmatism, look at the nature of astigmatism, whether it's corneal or lenticular or internal astigmatism which you need to deal with. Because soft multifocal contact lenses presently in the Indian market and most of the Asian market are only available for spherical prescriptions. So if astigmatism is more than one diopter, we need to think about how are we going to deal with that as well. And how much amount of electronic device usage do these patients have? Again, this will help you to choose the modality, and the duration of lens wear will help you to choose the material of the lenses. I always believe in asking open-ended questions. This will help us to get more information, relevant information. Avoid asking close-ended questions where the answer is yes and no. We want to understand their daily life activities. Let them explain to you what do they do throughout the day, and that will be very beneficial in choosing an appropriate design and lens for your patient. Next is we need to prioritize their needs. So they tell us about what needs they have, why they are going to wear these lenses. But now we need to prioritize. So what prioritization needs to happen? You must consider the primary need, whether it's going to be for distance, intermediate, or near. So that's the primary need what the patient would have. Then there would be some functioning environmental need. Do they have any gaze of direction shift, or do they have any direction of fixation shifts during their wear, depending on their occupation? And what is their secondary need? Are they going to use it for social or part-time occasions? Or they are going to use it for any events, or only going to use it for specific tasks? So this again will be very, very important for you to prioritize and eventually help you to choose the type of lens, modality, material, and design for your patients. For multifocal fitting or for presbyopic fitting, whatever design of contact lens you choose, the assessment of ocular dominance plays a very important and a crucial role. And there are two ways to actually measure or test for ocular dominance. The most common one is the sight dominant testing. So what do we normally do? We ask the patient to make a triangle or a diamond and hold it up close at about 40-45 centimeters and give a distance target. And we close the right eye and ask whether the target was still in the box or the diamond what the patient had created. And conversely, again, we close the left eye and check. So the eye where the target which you gave remains in that the diamond is the dominant eye. So that is sight dominant testing. The other way, what you can say is, ask the patient that imagine you're holding a camera, the olden days, the one which had the roll and the digital one as well. You're holding a camera and you want to shoot a picture. How would you shoot? So the patient would typically close one eye and, focus with the dominant eye. So that will tell you what eye is the dominant eye. But when it comes to clinics, in terms of clinical practice, we prefer to do the blur suppression method. So usually what do we do is we use a +2 or a +150 lens and we compare which eye the image is more blurrier compared to the other. So the eye which has a more blurrer image is the dominant eye. And this is more recommended, or this is a recommended way of testing for ocular dominancy in terms of fitting presbyopic patients. So the blur dominancy test, always remember that the patient has to be corrected maximum for the distance vision for each of the eye, irrespective of their prescription. If they have astigmatism, make sure the full correction of astigmatism is there. And as I said, the chosen mode of correction for dominancy is this blur dominancy method. Now, why are we checking this dominancy? Is we will always follow the DDNN rule, which is the dominant eye is always corrected or made stronger for distance, and the non-dominant eye is kind of made stronger for near. So that is the DDNN rule. Dominant eye for distance, non-dominant eye for near. This holds true for maximum number of patients, but you can reverse it if there is any occupational requirement or demand. So if there is a patient who needs very strong near tasks, you might want to do a dominant eye for near and non-dominant eye for distance. But again, this is a specific case which you will use for. But generally, we are using DDNN rule, which is dominant eye for distance and non-dominant eye for near. Now let's look at the subject proper, which is the contact lens options which you have for these presbyopes. The very basic and the commonly used option is monovision. So the name itself says mono means one, unity, and vision is correcting one eye for one distance. So what do we normally do is one eye, which is typically the dominant eye, as we said, the DDNN rule, one eye, which is the dominant eye, is corrected for distance vision, and the other eye is corrected for near vision. So when both eyes view binocularly, they can see distance and near simultaneously. So that is monovision, correcting the dominant eye for distance and the non-dominant eye for near. So what are the opportunities what we have for these monovision? If the typical monovision doesn't work, and I'll be discussing on the advantages and disadvantages in subsequent slides, but you can always do a modified monovision technique. So for example, you had fitted the right eye for distance and left eye for near, and that didn't work. You can modify it by probably placing the right eye with a multifocal lens and the left eye with a single vision near lens. So that is kind of a modified monovision to make sure that the visual outcome is maintained for the patient. Or you can go in for something known as enhanced monovision. Again, we are going to discuss about type of multifocal contact lenses later, but there are different designs even in multifocal lens. You have a center near or a center distance design. So what you can do is you can consider the dominant eye being prescribed by a D lens, which is the center distance lens, and the non-dominant eye you can prescribe by a N lens, which is a center near lens. And just taking a simple example, it's something like a car. You can modify the car and still you can use it to make it look more beautiful, or you can enhance the engine power and horsepower of the car to make it work more faster or efficiently. So these are some things which can create opportunities for monovision, and still a presbyopic patient can wear contact lenses. So in summary, what are the advantages of monovision? Of course, it is good for fitting patients who have reading aids of lower than 1.5. The only reason being you are creating a bit of an isometropia for distance as well as for near, because one eye is for distance prescription, one eye is for near prescription. So that's something which we need to look at. Clinical advice would be always measure the stereopsis with the monovision correction if you are prescribing it, to just make sure that the stereopsis does not drastically reduce. If the stereopsis reduces too much, it may affect the binocularity, and some task or visual tasks would be affected for the patient as well. It is easy to fit because it's just fitting like a single vision contact lens. You have one single vision contact lens on one of the eye for distance and one single vision contact lens for the other eye, which has the near power. So you have a large variety of range in terms of single vision lenses anyways available in the market. Toric patients can also be fitted because you have toric soft contact lens single vision available in the market. Variety of materials and modalities are also possible. Some practitioners do think that it reduces chair time because as I mentioned, it's just like fitting a single vision contact lens to the patient, but it varies from patient to patient. The adaptation in some patients might take a bit longer time because the brain need to adjust to that monovision kind of a pattern. So that's something which is debatable. And of course, it's less costlier in terms of expenses because they are single vision contact lenses. They are way cheaper than multifocal contact lenses. What are the disadvantages of monovision? Again, it is less effective with very low ads and very high ads on the other end. I would say very high ads because you are creating that anisometropia, and thereby reduction in stereopsis and contrast can happen. So it's always good to clinically measure if you are doing that. There is a bit of adaptation period, and it may vary from individual to individual. And it is unsuitable, of course, for patients who are monocular. The next option we have for these patients, of course, is the multifocal contact lenses. And I have restricted myself for this particular discussion. I'm not going to talk about the details of the design because there are different types of designs such as translating, aspheric, concentric, and all of that. So I'm not going to discuss that particular aspect, but I'm going to discuss more of a clinical part of fitting multifocal contact lenses. So we always need to understand that there is no single lens type or design which is ideal for everyone, because different patients have different visual demands, different ocular structures, as well as the optics which works differently. Of course, there is GP lenses which still continues to give higher success of vision because of the design and asphericity of the lens which is there. We also want to understand that who is more suitable. Practically, we say that all patients who have a refractive error, specifically the lower ads, the moderate ads, higher ads are slightly challenging to fit, but again, it's not a no that you can't fit patients with higher ads. It's just a bit of challenge which you can, of course, fit them with multifocal contact lenses. And with advancements of design these days, I think it's really easy to fit them as well. But most importantly, motivation. So patients must be motivated. And I think in my experience, patients who are already contact lens wearers are highly motivated. But practitioner's role here is really very important. Make sure that you explain to the patient about the multifocal design, and don't set up too high realistic expectation. Set a normal realistic expectation, so that if you hit the nail, and if you are getting more better, or if you achieve more, they'll be more happy. So don't talk too much high end about these multifocal lenses, because we don't really know if it's going to work for them. So just set realistic expectations rather than putting them or setting very high standards. Informing them, motivating them always while you're fitting them is really a key to success, and I'll be talking more about it in the future of consequent sites. Who do we fit? So patient selection plays a very important role. So we need to select our patients well. We want to make sure that the availability of the lens cater to their needs. Is there patients who are easier than the others? So there are certain debates, and people who are fitting multifocal contact lenses routinely do talk about it. And are there some patients who probably are much more easier compared to the other, where we compare hyperopes versus myopes? I think fitting a myope is slightly challenging, because they always enjoy their vision up close. Hyperopes wants to see clear, so it's much more easier to fit in my experience. Ametropes versus emetropes, again, because emetropes have enjoyed their whole life without wearing any distance correction, and now putting in a multifocal lens which will cause a bit of diffraction of rays of light, causing a bit of reduction in the quality of vision, would affect. Ametropes throughout the whole life have been wearing contact lenses or glasses, so I think slightly easier to fit compared to the emetropes. With the rule versus against the rule, astigmatism, low ads versus high ads, people who have smaller pupils versus larger pupils. Smaller pupils, patients with smaller pupils are relatively easier to fit because of the multifocal contact lens designs which are available. So an ideal patient selection, or choosing the appropriate candidate, I think is a really good indicator of success. So what are the basic designs of multifocal contact lenses available in the market? There is a center distance design, which means that the lens has the distance power in the center of the lens, and then you have a concentric or an aspheric design, to be more precise, having the near ring zone. And these patients would, if they want to read, usually they will in outdoors, they would probably need some tinted sunglasses. So reading outdoors with this design is a bit challenge, because we all understand that while reading, the pupil constrict during convergence and during accommodation. So it's a near triad, but then there is a distance power in the center. So when they are outdoors, it's sunny, pupil constricts, they would have difficulty to read. But if you put them with tinted glasses or shades or sunglasses to read, pupil will dilate because the amount of light entering is less, and they would do well with center distance design as well. On the other hand, we do have center near multifocal contact lens, where the near portion or the near power is in the center, surrounded by the distancing. And conversely, when they want to drive outdoors on a sunny day, because of the sun, because of the amount of light entering, there will be a pupillary constriction, and because of that they would be seeing through the near zone. So it's advisable for us to tell them to wear sunglasses when they are driving on a sunny day. So all these small clinical tips are important when we are dealing with these designs. So we have two basic designs. The D lens is also known as the center distance design, or we would refer it to a D lens. And we have a center near design, and we would refer it to a N lens. So what are the fitting pearls? How should we make sure that it's a success, and what should we be doing with these? Remember that centration is the key to success. If the lenses are well centered, I think most of the battle is won, because the zones and the aspheric design of the lens will work accordingly, and everything will fall in place. So centration is the most important key to success. If the lenses are not centered, the zones will be not aligned to the pupillary dimensions, and patient will complain of glares, halos, and disturbing of images which they would see. Always allow your patient some settling time. So once you put the lens onto the eye, give them 15 to 20 minutes of settling time with these multifocal contact lenses. This is to stabilize in terms of the anatomy of the eye, because we know once you put the lens, the tear film stability and all that is hampered a bit. So you want them to get used to that feeling, and also the vision. So since you have put a multifocal lens, there is multiple images now being received by the brain, and the brain need to decide and choose which is the clearest image and let them see clearly. So give them a settling time. Don't just rush into doing your over refraction and finalizing the lens. Ideally, we must always ask the patient that during this settling time, they can wait outside, not in the consultation room, but in the waiting area, so that they can look around, and it gives more of a natural viewing pattern rather than an artificial pattern. So they can look around, play their phones, read a magazine. Again, when it comes to read a magazine, avoid glossy print magazines. You can give them a newspaper which is not having that shiny layer, normal newspaper or reading material. That would be better, so that they get adapted to the vision part of it. And when you are checking the vision in your consultation room, always ensure that you have optimum room light illumination. Don't let it be too dim. Don't let it be too bright. Again, to make sure that the pupil is at its best size. We do not want to artificially, make the pupil larger or make the pupil smaller because of the room lighting. So that's really very important. And you can start over refracting the patient once you know that the lens is centered. Of course, you have assessed the fit, your push-up test, your lens centration, your post-blink movement, all of that is acceptable. You can start doing over refracting. The clinical pearl here is you do a binocular over refraction first. So let them see with both the eyes, let them read the distance chart, and then let them read the reading material. Again, when it comes to distance, I usually prefer to isolate the chart letters. If you have a computerized or a TV screen which you use for vision, I would like to isolate it in the beginning to get the benchmark of visual outcome. And slowly and steadily, you can put all the letters together to create that crowding and see. So make sure that all of this adaptation is something which the patient can go through. Remember to put in maximum plus and minimum minus as the refraction goes. And We tend to give a lower add in the dominant eye, again, because dominant eye is for distance. So we don't try to give more and more add onto the dominant eye. Forget the phoropters. That's something which you need to avoid while refracting, these multifocal patients or multifocal contact lens wearers. Is always good to use some loose lenses. Even the trial frame sometimes is a bit cumbersome. Use some additional trial lenses, a small flipper, something like this, which is shown, can be used, where you can put a plus minus 0.25 and see if there is any good visual outcome improvement. An ideal thing to note here is anything more than 0.5 of over refraction, which you require to improve the vision, is always good to refit them with a new power and check everything before you order the final prescription. The more the over refraction you change, the more the lens design on the final lens product would change as well. So I normally use a 0.5 or lesser of change in my over refraction. That's why I tend to use the loose lenses. And again, we are going to use the distance, the dominant eye for the distance, and the non-dominant eye for the near. Some more fitting pearls is follow the fitting guide. So each lens design differs from one another, and all of these manufacturers have done tremendous research, R&D, and come out with these different fitting guides for their own design. And I would highly recommend you to use their own fitting guides to initially choose the lens for the patient based on the prescription. And not only that, it is very useful in terms of troubleshooting. So they have these guidelines in place, and I think you should follow them very religiously if you choose that particular brand or a particular design to fit to the patient. So they are your friends, and remember to use them efficiently in your clinical practice. And when it comes to follow-up, so once you have a lens which gives optimum vision to your patient, you're going to deliver that lens, and patient is going to come back to you for their aftercare or for a follow-up visit. So what should you be doing? You should always listen to what your patient is saying, because they will tell you if they want more of a better distance or more of a better near, because they have experienced these lens wear for X amount of days, and you can then make changes accordingly. So listen to their visual needs, ask them specific questions. Were they happy for distance, or was there any difficulty? I normally tend to not ask them if they had any difficulty. I would more be of a positive approach here. So I'll tell them that, were you happy with your distance vision, rather than asking them what problems did you have in your distance vision. Ideally, both means the same, but we want to keep a more of a positive approach to the patient. Most importantly, remember that if contact lenses are falling short of expectations, make sure that the patient is as specific as possible. So you ask them, what is the task they are having problems. Sometimes, they are reading in a dim illumination. That's their task. They tend to read in the room environment, which is very dim. And just by asking them to use an additional lamp or additional light, or by making the room illumination normal, can sort out the problem. Even mobile phones, people tend to keep their brightness too low, or their screen protector nowadays have this privacy screen protector and all of that. So because of that, that's the vision problem. So we need to be very specifically asking them what's their problem and solve it accordingly. Not always contact lenses need to be changed. There are certain environmental modifications, like, as I said, giving them an additional light or making the room illumination normal itself can do wonders, or increasing slight brightness of their mobile phones can make wonders in terms of their vision outcome. Your patience, your perseverance, and a methodological problem-solving strategy will help you and guide you to have a success with the today's ever-improving multifocal contact lens design. So these newer designs are really wonderful. most of the time you would get a first fit or a second fit success, because they cater to the needs. And nowadays, since more and more people are fitting multifocal lenses, the feedback the manufacturers get, they keep on constantly improving the design. Not only the designs, the modality, the materials, the surface treatment and all of that, to make the lens more comfortable for the patients to be worn. What are some tips to success? So this is something which is you can keep in mind. Always offer trial contact lenses. Now, the reason behind doing this is when you are doing fitting for multifocal lenses, you are going to do in your clinical setup. It's going to be a 1-2 hours, probably 3 to 4 hours of wear on an exaggerated basis. But the most important is when they go in their own environment and start using them for a couple of hours more, 6 to 8 hours on a daily basis, you want to make sure that they are more comfortable. So it's always good to offer, trial lenses for patients to be worn and experience them for a couple of days. And I think it's really possible because all of these leading multinational contact lens manufacturing companies do support with ample of trials, and you can ask them for the trials for the patient as well. Always encourage and reassure your patients. As I was mentioning, use a positive approach rather than asking the same thing in a negative way on what problems do you have, did you enjoy, or how well was your distance vision. So using a positive approach really helps. Manage any limitations positively. So if they are complaining of near vision problem, try to manage their near vision. If they are complaining of intermediate, try to manage them positively. Do not provide an array of problems. Don't really tell them that you're going to see halos, you're going to see lights coming out, you're going to see multiple images because it's concentric design and all of that. Don't provide them with all of the problems when you're fitting them, because that will again be there in the back of the mind, and they'll keep on thinking. Even if they see one shadow, they'll start complaining and they want to get rid of it. So do not provide them with a list of problems. That is what I mean to say. And don't perceive it as a complex contact lens fitting. It is a challenging thing to do, but with adequate chair time you spend with your patient, I think it's really a smooth process and not really a complex fitting process at all. Always stay positive, because if you as a practitioner are positive, you can of course convey this emotionally as well as in your conversation to your patients, and eventually they feel motivated as well. And positivity will lead to motivation, and we did talk about that motivation is a very important factor for the success of fitting multifocal contact lenses to presbyopes. So what is the way forward? What are we looking at? What are the advancements which will help more and more presbyopic patients to wear multifocal lenses? And one of it is, having multifocal contact lenses for astigmatism or toric multifocal lenses. We do know that a lot of population percentage do have astigmatism, more than one diopters, and they might need a toric multifocal contact lens. So this is something which we are looking at. It is launched in some parts of the world and very easily available. But I think in the Asian market, in particularly in India, we are still waiting for companies to launch a toric multifocal lens. And again, I would like to emphasize here that if we start more fitting multifocal lens, the demand of multifocal lens market would increase. And then eventually they'll have to bring in toric lenses because the demand will increase. Currently, the demand is not that great, so they would not launch it because, of course, there is not much of a demand. But it's really important for us to start fitting more vigorously to multifocal patients, to presbyopic patients. And once the demand is high, I think it's the future is very near. The other thing is there are RGP lens with multifocal design. So if patients who require higher astigmatism, higher toric or astigmatism patients who require these designs, there is an availability of multifocal RGP or rigid corneal lenses as well. We also are looking forward to have customized design in terms of scleral lenses. So patients who are wearing scleral lenses and are presbyopes can enjoy their distance as well as their near vision. And last but not the least, we also have hybrid contact lenses in multifocal designs as well. So this is something which is available in some parts of the world, but I think it will be available soon in the Asian as well as the Indian market once the demand is high. Again, I've just put up these examples and these brands just for your knowledge, and no financial interest on any of the brand which I've put up on the slide. So with that, I would like to thank you for your patient listening and gear up yourself. I would say multifocal contact lens requires to have all your tools in your toolbox ready. Once you are ready, once you understand the design, and once you know the fitting process, and I would like to emphasize again is the importance of the fitting guide. Once you know that thoroughly, I think you would be able to successfully fit a presbyope with multifocal or with monovision or any type of modality contact lens to these presbyopic patients. Remember, we want everyone to see the rainbow and we want everyone to see clearly. So make sure you give it your best shot in fitting these patients. Understand their needs first before you choose the design. And once they come for a follow-up, listen to them and modify accordingly. So I wish you all the success in fitting your patients, your presbyopes with multifocal and with presbyopic contact lens options. Happy practicing. Take care, be safe, and hope to see you around sometime. Bye-bye.